Hey everybody, this is Dr. Ben Pearl, and I am here today and we're going to be talking about research in podiatry. And we have two residents. One is a second year, Ashlee Starr, and the other is a third year, and I guess getting ready to complete his program, and that is Dr. Patel. So welcome to this podcast. And, this is both meant to be instructional for people that are interested in doing research, but then it's also going to be specific because we have some things that we have to hash out with an IRB that we're looking to do on Sever's disease. So first, welcome guys, and maybe Ashlee, you can kind of kick things off by telling us a little bit about the IRB process.
Yeah. So I'll speak specifically to residency programs IRB a little bit, but it's all kind of generalized the same way. It kind of all has the same format, but for us specifically at Ascension, you have to do city training, which across the board is standard for any IRB. And apply for a specific IRB account, and then they have their own IRB application that you have to fill out, which asks certain questions like what's your planned protocol and things like that.
Okay. And then in this specific one that we're doing through your residency in Indianapolis, tell me, Dr. Patel, what the city training is all about.
Yeah, essentially the city training is just a way to make sure that not just our research project, but any research project is being done ethically and morally correct, abiding by federal regulations and ethical standards, ensuring that patients are safe, treatments are done very systematically, and that everyone involved in the process is aware of kind of what we're doing, what the goal is, and just making sure that we have that standardized training and ensuring that we're doing things the correct way.
And we were talking off camera about some of the things that people might not know about what is permitted in a study. And we were discussing things that would happen in the normal course of treatment for, let's say, plantar fasciitis, or in this case, we're investigating Sever's disease, which is a children's growth plate anomaly or problem that occurs during the growth spurt for young adults, or for it more like adolescent age. What are some of those concerns, and what are the answers in terms of what is ethical to do in terms of payments by patients when partaking in a study?
Yeah, so for some of the studies that we have going, and in the specific one that we're doing on Sever's disease, we will bill an office visit, even if the patient is involved in the research study. And the idea behind that is you're giving the patient the standard of care. You're still going to treat the patient the way that you would without doing an extra step. So in this situation, there's an extra treatment that we would do for Sever's in addition to heel cups. So heel cups would be essentially why we're charging an office visit. That's the treatment. And then this additional treatment that we would be doing, they would get for free. So there's another study that we're doing on fungal nails. And similarly, we charge an office visit for that as well, providing expertise on fungal nails. Patients always have questions if it's going to go systemic or things like that. So really, you're still charging for your time, but the treatment that you're getting is compensated.
So to briefly summarize, because the heel cups are considered one of the controlled variables that you're doing in both study groups and not the study variable, it is okay that you would charge the standard charge that you would normally do in the course of the interaction with the patient.
Correct.
So maybe one of you can take me through the timeline in terms of expectations after the parameters of the study are set. We have to determine treatment length, treatment protocols for power of the unit that we're going to be using. In this case, it's a pulsed electric magnetic field device, also known as PEMF. Can one of you explain, once we define how many patients we're going to get and the duration of treatment, what the next steps are for obtaining the IRB in terms of the application process?
Yeah, so it's kind of variable depending on your IRB committee. There's some, for example, the IRB for my medical school, going through that one, it took, I would say, about 4-ish months to get approval, for back and forth, depending on how you formulate your study and how many corrections you need to make to your protocol that they don't like, or XYZ. There's always a lot of variables to it. Some other, depending on how in-depth and clinical and the level of which there's risk involved. So more clinically based studies where you are giving a patient treatment. I think across the board, those tend to take a little longer to get approved from IRBs, just because there's inherently more risk to that than, say, a survey study or something to that nature, where that's pretty benign. There's not a lot of risks. So, that tends to get pushed through a little faster. But every IRB is different. Some are a little more finicky and particular than others. But I would say at least a couple months, and that's probably ambitious.
Yeah, as you mentioned, there's going to be comments, and then we would address those comments and concerns.
Exactly. Yeah. So you're looking at multiple revisions typically,
Right.
just
Right.
normal and standard, because you're just trying to figure out what the IRB wants. And I mean, even within the same IRB, there's different people reviewing it. So just because,
Yeah.
they wanted it one way one time doesn't mean that it's going to be identical the next time.
And then to sort of add on to that, even once you get approval for a study and you get going, especially with a clinical trial where you're trying a new treatment for a specific condition, the IRB's job is to continue to monitor the research to ensure there's continued compliance, and that the study, and that includes sort of reviewing any changes to the study that you may make while it's going on, or monitoring adverse events to that certain treatment. And also conducting periodic reviews of the ongoing research itself to make sure that everything's still ethically standard and maintained.
And what is the typical way that the validation is done with a remote center like mine would be? I'm in Virginia, you're in Indiana, and the review process is going to be conducted through Indianapolis.
Right. So essentially, I mean, when you're first starting out, right, the IRB is going to go through the study design, the risk to benefit ratio, informed consents, the protection of patients' rights and welfare's documents. There's a series of documents you have to fill out and go through, and it'll be listed that this is going to be a multi-center study that's going to be regulated, and the database essentially will be evaluated through Ascension. So we have to ensure that we have a HIPAA compliant database like REDCap. So once we have them approve the process, then it's, are we filling out REDCap appropriately? Are we filling out the adverse events section in REDCap? And they would have access to that to be able to monitor kind of what's going on. So essentially they would look at the database, and also from us expect that if there are any severe adverse events, also report that directly to them.
And because my EMR is going to be a different EMR than the Ascension program, what is the process for integrating the medical record? Or are we just going to upload the pertinent data on the scores of the subjective scores that the patient give us on improvement, from both the control and the study variable group, enter that data without loading the full EMR record?
Yeah, exactly. I mean, every patient will have their own identification number, and we would only upload and input in the relevant study details along with adverse events.
So somehow I would need to communicate through some portal what the data was that the patient was reporting so that it could be done, or would the patient be doing a questionnaire that would go internally into a portal? How would that step take place? Without getting too much into the weeds, I mean, just to know maybe simplistically how that process usually goes.
So
Yeah,
that's what,
go
go
ahead,
ahead,
Ashlee.
that's what REDCap's for. So REDCap, you would import the data into that, depending on if you wanted to do a survey analysis. If you did that, the patient can actually fill it out directly on REDCap through like an iPad or something like that.
I
I did a
see.
previous study where all of my surveys were directly on REDCap, and they filled it out there. That way I didn't have to transfer anything, and that kept the survey completely anonymous. When you have specific data, like he said, they're given a code or a number, a patient ID, that tries to keep it anonymous too.
Great. As far as looking at what we're proposing specifically, we looked at the possibility of dropout if we told the study subjects that they have to shut down athletic activity for too long of a time frame. So happy to sort of kick this around, but after talking to Dr. DeHare, it was thought that it might be only a period of 1 to 2 weeks, and maybe only 1 week, that we would shut down athletic activity completely, depending on, I guess, meeting some of the other criteria with how painful we're going to allow the patients that presumably don't have to be offloaded, because we felt that if we start offloading patients, that would introduce yet another variable. And in most cases, most practitioners, 90% of the time, are not using a cam boot or full offloading for Sever's disease. So we thought that that would be too severe of a variable to distort what we're trying to test. So we're looking for a range of patients that would be ones that would be loading, and then we just have to determine how long we would shut down the athletic activity. Any thoughts on that time frame for shutting down athletic activity?
Yeah, I think I would agree with the shorter time frame, because the longer that you put a restriction on physical activity, especially outside of your office, you don't know what they're doing. So that's a variable that is not well controlled. And, patients can come back and say that Bobby was not playing his sports, but he was, maybe still running, playing tag outside all the time or something else. So activity is a pretty subjective question, and patients, that would involve a level of compliance that I don't think all patients have, as we know. So I think the minimizing that variable as much as we can is
So
gonna.
Niral, in your estimation, and I see where Ashley's thinking about this, and I'm, very closely aligned. It's just a question of degree. Do you think that we should put no restrictions for the purpose of the study participation on activity level that they would continue? Or would we suggest something to the effect that they might shut down activity for 1 week to be the inclusion criteria for the study? Any thoughts on that?
No, I kind of agree with what you, Dr. Dehere, and also Ashlee kind of mentioned. I think the 1 week, you know, them agreeing to be not active for 1 week or not doing their typical sport for a week would be reasonable and eliminate the variable.
Yeah, that way, even if, for instance, there was some limited activity that was occurring, it's only for that 1 week. And for the purpose of the duration of the study, I'm currently, as a test volley, treating a patient as a potential sort of initial protocol that has Sievers bilaterally. And it's along the lines of what we discussed. I have a certain strength level that I'm using for the Gauss and the frequency on the machine for the PEMF unit. And we have also dispensed a heel cup. Now, in this case, it wasn't randomly assigned. So I guess the next thought process is, initially, I'm thinking somewhere in the neighborhood of 4 to 6 weeks as the max that we would be doing for treatment because of attrition. But open to thoughts on how long we should conduct the treatment. I'm thinking, if possible, 2 treatments within 10 days, per 10 days, to not make it too restrictive if there's travel, school holidays, those type of variables that could then make twice a week just not possible. Kids that are, going to mom's house, for half the time, and then dad's house, and then dad might live an hour away, like that. Those are other things, socioeconomic factors, etc. Thoughts?
So then you would be doing, essentially, if we did it for 4 weeks and you're doing 2 every 10 days, about
That
6
would be
treatments
6
total.
treatments, 6 treatments
Mhm.
total. If we did
Yeah.
it, I'm sorry, for 6 weeks, right? So each successive 10-day frame would, for the inclusion criteria, we would want to try to get 2 more out of it. So if we did 1/3 of a month, then we would add 2 treatments. So that'd give us a total of 8 treatments.
Between 6 and 8. Yeah, I think that's a good length of time. And then I think if you could get patients to follow up after that, even after treatment stopped, to see if any recurrence has happened or anything like that, I think that would also potentially be beneficial.
You guys have any thoughts on an endpoint for final evaluation for recurrence?
Niral, what are you thinking?
Probably somewhere between the 8 to 12 week
I was thinking 3 months if possible.
range. Yeah, that would make
Beyond
sense.
3 months, I don't know how realistic it is to have anything continue beyond 3 months. So
Yeah, I would agree.
All right. What are next steps, Ashlee, to move forward? How do we get
So,
writing and start the process? Obviously we want to review this with Dr. Dehere, which
right, yeah.
he wasn't able to make it tonight, but I'm sure he'll be on the next. We'll have at least one follow-up call and maybe a couple.
Yeah. From the residents' end, we're going to start getting our IRB accounts and everything like that. From your end, you're looking, we have to just finalize the protocol Once we have the protocol in place, from there, the application's fairly straightforward, I would say. So,
How should we handle the testing centers without having full commitment from two of the prospects that we might include in this study for the
yeah.
submission?
So I think we have a little bit before we submit the IRB. So if at the time that we choose, when we do submit it, if we don't have confirmation that these other testing center sites are committed, then I would go with what we do have, which is your testing center, and then we can submit for an amendment later if we do have an additional testing center site. You
Did you
agree with that?
Did you have a chance to speak with the biostatistician in terms of what would be a relevant number of patients in total for the aggregate of the study group of the study variable and the control group?
Mm-hmm.
I mean, we could follow up with that if not.
Yeah, once we get our protocol, I can send them a better idea of what we're looking at and exactly what we want to study, and then send that to them and see if we can get a number for you, or at least a
It's okay.
ballpark.
So it's okay at this stage to be sort of open-ended then.
Yeah. We'll get what we need before we submit IRB.
All right.
Typically, that is a question. So,
All right.
Yeah, and while we're creating this protocol, it would be helpful if we could, because the statistician is going to do a power analysis to kind of determine this is the minimum number of patients we need for this study to have any sort of impact on the literature. So as we're kind of creating the protocol, obviously we'll do some sort of literature review. So we could send, compile that into a folder and compile those studies on anything that maybe not exactly this treatment option, but anything that has been done to treat Seaver's disease. We compile that list or that folder of studies, and we can send him that so that he or she that, and then they're able to do the power analysis a little bit easier and don't have to do as much literature review.
Yeah, and I can tell you straightforward that you will find that there is absolutely no literature on pulse electric magnetic fields for Seaver's. However, there is study data out there for osteoporosis and osteopenia, as it's been well known for several decades that pulsed electric magnetic fields have been used in bone stimulators and have been proven to improve bone density scores with randomized controlled trials. So that was the basis of why I thought it would be a good study element, and the fact that during the process of getting Seaver's disease, there's a transient osteopenia with the hormonal changes that occur during that phase.
Yeah. Oh, that would be perfect. Yeah, if we could, do a power analysis on specifically that, and then kind of base that to find our minimum number. Statistician would be able to do that. And I'm glad that we've already kind of looked into literature for that.
Yeah, I believe I forwarded you some of those studies, Ashlee, but if you don't
You
have,
did.
yeah.
I'll create a Google Drive, a folder, and I'll share it with everyone who's involved in the study. So Niral, Damien, and Dr. Pearl, you'll be on it.
Great. Well, before we close out, does anybody want to share anything that they are excited about with, in brief, the research that they're doing, or what this phase of the residency program has, meant to them?
Research is really important. It's what drives and makes our profession better and keeps us growing and keeps us accountable for what we're doing and why we're doing it. So,
Anything to add, Niral?
Yeah, I mean, I completely agree. Evidence-based medicine is always the goal, and the more evidence, the more literature, high-level literature we have out there, the better for our patients and for ourselves in terms of getting the outcomes that we want.
Mm-hmm. Well, listen, man, I commend you guys. You're working hard. to, do a Zoom call here at night during the weekday when you could be watching old I Love Lucy episodes or working out at the gym or whatever else you do to decompress.
We appreciate you having us.
Yeah, absolutely. Happy to help with the study. It's
Okay,
exciting.
guys. All right, look forward to the next steps.
All right. Thanks, Dr. Pearl.
Okay, have a good night.
Thank you.